Rucker.
So really, panelists did a great job. Frankly, I'm glad I didn't bet my paycheck on everybody's keeping on time, because I would have bet against it, and it happened. So thank you very, very much. Obviously, you've figured out there's a tremendous amount of detail in these very small 10-minute presentations, and I encourage everybody to dive into the details. We're going to have more this afternoon. Genevieve Morris, our Principal Deputy National Coordinator, is going to be shepherding some of that. So we're going to have a lot more. We have a month-long comment period. So this is really the start of the dialogue on, what kind of frameworks we are going to have for us to get to where we would like to go. Now, to talk about where we would actually like to go, right? Because ultimately, some of these things tend to have a little bit of a provider-centric approach to them, and, guilty as charged as somebody who's been a doc for 30 years. But sometimes it's actually hard to remember exactly the patient's view on all of this. So I look around, many of us have been in the industry for decades. I've known many of you for long, long periods of time, but it's nice to get that outside perspective. And for that today, we have Cynthia Fisher. Cynthia Fisher is an entrepreneur. She started one of the very first cord blood companies to allow stem cell transfusions to treat diseases like leukemia. This is now a billion-dollar business that she sold to PerkinElmer. Just to give you a sense of the scope, Cynthia has vast experience getting complex healthcare technology through the FDA stack, maybe somewhat resistant providers who maybe didn't really quite see the benefit of that, and is going to share her perspective. She, has an undergraduate degree from Ursinus College in biophysics. She has an MBA from Harvard Business School. Her current business activities focus, among other things, on renewable water resources. And the one little maybe social note for folks who are keeping track, her husband, Jim Cook, founded Sam Adams Beer. So that's another kind of interoperability as well, I'm guessing. Cynthia Fisher.
I like to move. Thank you, Dawn. I guess you could say I've had a career focused on blood, water, and beer, liquid assets. And I've also focused on our health information and our health data. One could argue that data, too, is a liquid asset. Why? Because in order to work, it needs to flow. And right now in our healthcare system, to physicians and patients alike, it doesn't. It's frozen. It's frozen in the institutions of care and in the software providers that provide us our electronic medical records. It needs to thaw. Today, physicians and patients alike need to travel with tenacious ice axes and navigate waters from institution to institution to try to get access to the critical health, life-saving information. And today, we as patients get care wearing a blindfold, blind to a complete picture of our profile, and we're bound by having to get care from the institution that has the most of our information. We're bound to stay stationary, and yet we live in a mobile society. On top of that, we are expected to turn over a blank check for whatever care we get with no visibility to cost. In order to change this brokenness of today and access, we need to turn it on its head. We need to approach it not as we are here today as professionals for this complex problem of interoperability, but we need to approach it in our collective self-interest. Our collective self-interest as we, the patient, we, the customer, the consumer, and we, the caregiver. Let's talk about access. I don't know about you, but in my family, I happen to be the one that is the designated driver or personal valet of my family's healthcare information. I'm the one that tries to get the access from institution to institution. And I'm sure in your families, there's a person, a mother, a daughter of octogenarian parents, and a friend who has friends who live alone who've asked me to be their proxy. Like me, I'm sure each of you has your own story to tell of the challenges of access. Well, my friend Harold, an octogenarian himself, a bachelor who lived alone, had a hip replacement and needed his path report because he was being treated with his infection at another hospital in Manhattan. In order to get access to Harold's path report, it took 3 weeks, several faxes that were unresponded to, and finally, when one was, we had to receive by written mail the invoice first of the fee to get access to that path report. $75 later, and 3 weeks later till they got our check by regular mail, we finally got the path report. That's right. 6 weeks later, arrived Ream 1. Let's see if I can show you. Ream 1 and Ream 2. 2 stacks of paper of his medical record, and guess what? No pathology report. So access is really unresponsive, untimely, and unreliable. Case in point, in managing now the care for 10 people in my life, and mostly the 3 octogenarians, we found it most easy instead if we went across hospital systems and assimilated the pertinent information from their files. Hence, we proceed with a mobile, this is our mobile medical file. Thank goodness that when my father collapsed next to the coffee table in his apartment, the EMTs saw this binder, his binder, on that coffee table and were able to give him care, saving his life, where he's with us today. And yet, he got his main care at another hospital 2 miles away, which was totally locked down in their electronic system. We can change this. We can make it happen. Access doesn't work. And what can we do? This problem has been solved before. We actually don't own our medical records. Can you believe that? We don't own them. They're owned by the providers that provide us a service and the software companies. However, it's our health. We're the patient, and we're the ones that need this data most. So we need ownership. As we look to solve this problem, we need to give ourselves, the patient, ownership of our pertinent data and have it readily accessible at any time. We're the customer. We paid for it. How? We paid for it through our wages. Our employers save a part of our wages so that they can provide us health insurance. We paid for it through our out-of-pocket monies, through our co-pays, through our premiums, and through our deductibles and fees. And finally, we've paid for it a third time as taxpayers. We've paid for helping our government subsidize for those who need health care and cannot afford to pay it. We own it, we paid for it, we should have it. And we and the companies that we work for and insurers should be able to have broad visibility into the costs. We need transparency to know how much this is costing us, how much it's costing our companies, so that we can analyze the data and so that we can choose the best quality of health care at the lowest possible cost. And yes, we need transparency not only of costs, but of quality. When we have these three things, it's game-changing. And gosh, how do we do it? Don mentioned the mobile phone at the beginning of the speech. We run our entire lives on this mobile device. We are not stationary. We are mobile, and we are dependent on our mobile devices. This has been done before. In fact, the model pre-exists beyond any of these barriers that we present. The model has been done in the financial services industry, in banking. Secured access, instantaneous. Can you imagine the value of having your pharmacy pills instantaneously populated onto your medical record that's in your hand at all times so you can get access anywhere, anytime? Well, I'd say that this has been done before us in banking, but it's also been done in healthcare. Don mentioned my Viacord business, where 25 years ago we pioneered a service to allow families to collect, test, type, and store the precious life-saving stem cells that were left in the placenta and the umbilical cord of their newborn child. In order to do so that these cells and their health information would be there for that child for the remainder of that child's life and accessible anywhere around the globe, we had to use model. And our trusted framework, we needed our patients to trust us like they trusted their monies in their bank account. So we used the financial banking model for banking cord blood. Why can't we bank our health medical information in a similar vein? We decided that it was so important to give the patient ownership. That child owns those cells, and the parents are the guardians to majority. We gave them transparency of the quality of our service, and they knew up front, before they even chose to do it, they knew how much it would cost them. And then we also gave them the choice that they could give birth anywhere. They could go to any facility around the globe and choose to have our service done for them. And finally, we wanted to protect them for the future, and we wanted to make sure that it would be there for them 100% of the time. What did we do? We created the gold standard to secure and safely provide the handling of this precious resource. And yet, we knew it was important that we enabled a gold standard that allowed for an open and free and competitive market. We can do the same with our health information. Let's solve this problem for us, for our collective self-interest, as we the patient, we the consumer, and we the family caregiver. Let's give the keys. Let's give the keys to the patient, and let the patient be the driver so that the patient can be in control of his and her own future health and future wealth. Thank you.
Cynthia, excellent. Thank you very much.
Thank you.
Appreciate your taking the time to talk to a bunch of us in the IT space, but I thought it was great to hear that perspective. we are now, just in the interest of mundane organizational things, after a wonderful presentation, going to come back at 12:45, and that gives us a little margin. And I don't know who's, in terms of getting folks upstairs, Lee.
We will have escort straight up these elevators right here to the penthouse level. Is that you take that cafeteria, and we'll have escorts out in the hallway. You have any questions?
So we'll reconvene in 1 hour. Thank you very much.
Thank you.
Great.
Thanks,
Thank
Don.
you very much.
Thank you.
Wonderful.
If it's yes. So we wanted to kick off the after lunch session with a sort of a panel discussion and a little bit of Q&A. What we're going to do is we're going to start with a reflection on what you heard this morning from these organizations. I'll give them a little bit of a heads up that we're going to do a lightning round. If you can tell us in about 30 seconds what you believe out of what you heard this morning is the most important element for establishing trust in health data exchange. Then we will move to a Q&A here in the room. We'll start with the room, and then we will move to folks who are on the phone or via webinar who've been submitting questions. So with that, why don't we start from the left side of the stage? We'll start with Aaron. If you can reflect a little bit on what you believe might be the most important element for establishing trust in health data exchange.
So, trust for point-to-point exchange and encounter environments and so forth is one part of the equation, and we want to build on that. The most important part is to have the consumer involved in those transactions, because he's the only person who is engaged in each and every encounter, regardless of, if it's at KP or if it's at, some psychiatrist who specializes in treating only people who are bipolar and schizophrenic. We want to be able to make sure that whatever trust framework we establish ensures that a consumer can get access to their data, regardless of the networks that are being employed by their particular institution.
Great. Marianne?
Well, that's a very interesting question. I would have to say representative governance. For there to be trust, those who are parties to the exchange or the subject of the exchange should have a voice in the governance and the oversight of that exchange. And that is certainly a lesson that we've learned, and I think that's why so many of these efforts, if you look at it, it's the governance part of that.
It's going to be a challenge as we go down the line and everybody has to add something different, right? Because we're certainly going to agree with a lot of it. I definitely agree.
If it's the same, that's good news for us. So.
Oh, it is? No, come on. I'm going to make life a little bit more difficult than that. So, one of the other aspects I think about is that there is, if you think about all these entities in this huge country who want to participate in exchange, they don't know each other. They're arm's length at best in communicating with each other. So I totally agree with the unifying principles that Marianne and Aaron brought up. Another aspect of the same thing is just acknowledge that the agreement that you're participating in and the policies to which you're adhering are the same that everybody else is adhering to as well. So that there's this idea that is fairness and non-discrimination embodied in the policies in which you are participating.
I would agree with that wholeheartedly. I mean, the challenge in identifying the single most important thing is that there are so many elements that are necessary but in themselves not sufficient. So obviously having the stakeholders bought in, involved in the governance and the creation of the trust framework is critical. Jitin's comment, I agree with that completely as well. I'd add to it that ultimately for anything to be trusted in the environment that we have where there's perceived or real liability involved in the release of information is accountability. Right. There needs to be true accountability for all the different parties that are involved, so that people can know I'm not just trusting you because you told me to. You know, there's some actual basis behind why I'm trusting.
Well, a couple comments. One is I think we're using trust as a shorthand for security and trust. It's really always the issues around security and the prevention of privacy breaches is really always very important. The second point I make is that trust is always voluntary. So people have different levels of trust that they may need to have in place. So if you're dealing with the federal agencies, for example, the trust security controls have got to be very, very strict. If you're giving permission for somebody to access, you know, your Facebook account or whatever, it may be much different. The third thing I'd say is that identity is part of security, and increasingly, I think identity is going to be a very important part of it. Right now, we've relied way too long on passwords and IDs, and we need identity. And then finally, there has to be a business model somewhere, because hypothetically, trust for exchange is great, but really, when it comes down to it, is somebody has to pay for that information exchange to be exchanged, and they have to pay something. The question is, how much do they have to pay, and how can it be done at a very strong economy of scale?
Walter?
Yeah. So. I have many similar comments. I was going to say four things. I think governance is a critical element, and representative governance, as what's mentioned, is key. I think one that is a little bit different from what David was saying, it's an expansion probably, is trust is not just security necessarily, it's also legal. So a legal framework, a good legal framework is critical for building that trust. The third thing, which I think hasn't been mentioned, is transparency. I think it goes with the accountability concept a little bit, but I think transparency is the third. And I was just going to add the fourth is the business purpose. So it's a little bit different also from David in the sense of who's paying. I think is the other side of the business purpose is what's the value.
Sure. Ryan?
Yeah, again, we're kind of running in a different lane. So I certainly would agree with all of these on the HIPAA side. I think from our perspective, it's a consensus-driven approach to developing a remote ID proofing standard across systems using open standards. We feel as though our bar for consumers' access to their digital health information, it's much lower than many of the bars you heard earlier related to HIPAA. They have a higher bar to meet, and it's because of HIPAA related to it. Our bar is actually very low. As it means when a consumer requests their individual right of access to their medical records, it's obligated under law. It's not optional like it is under HIPAA. It's mandated under law that they provide that information. So our trick is, can we truly ID proof someone across systems? And if we can do that, then we can be able to meet that lower bar and provide a much more data fluidity with regards to the information for the consumer.
We're getting online questions. Please introduce with full name and the organization you're representing. Sorry to the folks on the webinar.
I'm Dick Thompson. I'm not Dr. David Kendrick, who's on a call that has extended. So relative to the discussion here, I concur. Data use, business purposes, governance. And I think the essence of the problem is that we probably need to re-look at HIPAA as we're looking at the delivery system and payment system reforms that are rapidly evolving. I think the lines between treatment, payment, and operations as articulated in HIPAA and the regulation need to be rethought under this new paradigm. So oftentimes HIPAA is used as an excuse to not share. And so I think if those lines are now blurring, and I think relooking at that regulation would be very helpful.
So just so you know what we're doing, we are receiving questions from the webinar via text. So I don't want you to think we're paying attention to other things. Let's start with the room and questions in the room first. And if you raise your hand, I'll bring the microphone to you.
Hi, everyone. I'm Deborah Green. I'm an Executive Vice President with AHIMA, the American Health Information Management Association. Thank you very much for everything you have shared this morning. I've heard two descriptors for trust. One was security, and the other one was legal. But what about trusting whether or not you can believe have? And here's the other thing. We've talked about sharing everything or exchanging everything from reportable conditions to entire medical records, right? So it's beyond just data. It is information, right? So in our way of thinking, and when I say our, in terms of the health information professionals, broadly speaking, our members of AHIMA and those who carry our certifications, we really see that you've got to have accountability. Even though you are not creating the information and the data, you've got to make sure that in this framework that what we all do is ensure that however the data are captured, created, the information is prepared, that it is integrity, accuracy, timeliness, comprehensiveness, that it basically meets all the characteristics of quality data that we call out. So I may have some more, but I want to leave room for other people's questions and points. But that's one thing that I think it's important that we address, that it's beyond the exchange and the technical standards. It's actually the content.
Do you have any feedback to that?
Well, thank you, Aaron, for putting me on the spot. I am holding the microphone, I guess. No, I think you're absolutely right that it is important to not only, well, let me state it a little differently. We're not exchanging for the sake of exchanging, right? I mean, we're exchanging because we're trying to deliver content that will be meaningful for a particular use case, whether that's treatment, the patient's own use, a payments type situation for payers, whatever the purpose. There obviously is real business why we're sharing information, and getting the content right and making sure that there's accountability around that content is certainly something that should be contemplated by any trust framework.
This is Dick Thompson representing Chic again, and I would reinforce the idea then of data quality, which is typically driven by the business reason behind that data quality. If the reporting doesn't end up in some kind of aligned financial incentives around that data, then the data becomes highly variable. So I think putting those incentives together and in alignment also helps the data quality, which helps trust. And I would articulate that many of our HIE members are now aggressively moving into connectivity with human service agencies like housing authorities, adult protective services, in addition to behavioral health. So there's a whole new level of trust among a whole new different category of consumers that are very important when we start moving upstream from health care into the social determinant side of this equation. So I think this trust conversation is a deep one, and I think it can be done with both standards, with regulation, but it also is a human-to-human thing because we have to be able to hold ourselves accountable for the data that we share and the purpose for which it is shared.
Anyone? Blair?
Hi, I'm Blair Hedgepeth with the American College of Physicians. I was just wondering about cost for these types of networks. Is there a cost associated with it? How is that cost determined, and who pays it?
Well, this is Marianne Yeager from Sequoia. With respect to the eHealth Exchange network, network participants pay an annual fee ranging between $5,000 and $20,000 a year, and it's based on annual revenue, or if they're nonprofit, annual operating expenses.
Sure. On the line. The way Commonwealth works with this centralized infrastructure we've created for being able to tell where the patient is and get their and to find their records, and then to query the data from those endpoints where those records exist. To put up that infrastructure, the way we decided we would kind of fund it in a way that makes sense and is sustainable is our members, who are HIT vendors primarily, those who subscribe pay an annual subscription fee for the usage of that service. And then, part of what they sign up for, literally, when they sign up to join Commonwealth, is a pledge to keep those costs reasonable back to end users. Because we're a nonprofit that's facilitating this type of exchange, I don't actually know the numbers unless they're published. And thankfully, a number of our members have published it, so they're usually almost zero, or if not zero, costs back to the end users, who are typically providers and patients. But that's the way it works for us. So we have our members who specifically subscribe, and then because they're subscribing to an all-you-can-eat model, they're very incented to amortize that cost by driving exchange to as many of their customers for as much exchange as those customers desire.
This is Dave Castle from Care Equality. I guess Care Equality from our standpoint is similar in structure. Actually, I think somewhat to both Commonwealth and its membership model and to the health exchange. But generalizing up from the specifics of what each of us do, I think it's important to recognize that there are different business models for different networks because they're providing different value in different ways, and that's a good thing. The business drivers are leading folks to figure out, oh, this is something that's valuable for me to pay for, and I'm therefore willing to pay for it. And so each of us has our own different models that for funding that all really derive from the business case ultimately that we're trying to meet and the value that we're providing within the industry.
For direct exchange, there are various different models for payment. Remember that direct exchange works over the internet, so there's no additional fees for using the internet. There are additional fees for making the internet secure and for the encryption to occur and the identity verifications to occur. So someone is paying somewhere between $10 and $15 per month per direct account. And that's paid for in very different ways. In some cases, it's paid by the EHR vendor. They absorb that fee to provide their providers. In some cases, the providers pay an additional fee to their EHR vendor or to the health information exchange. Some health information exchanges provide direct exchange addresses and accounts for free to their members who are paying a fee to be a member of the health information exchange. There's lots of different ways. But if you compare that cost to the cost of faxing or to a VPN, which can cost $80,000 to establish and $15,000 for one connection to another for one-to-one, direct is generally speaking the very, very inexpensive way of exchanging securely.
I think we'll take one more from the room and then switch over to some of the online questions.
I'm Will Schaefer. I'm the medical director for the American Academy of Orthopedic Surgeons. So I see myself and my members as one of your end users. My practice in northwestern Iowa, 9 county hospitals on any one night, 9 different EHRs, 9 different PACs. Am I looking at 8 different exchange that I'm going to have to purchase to cover, my patient population? Or am I looking at 1, 2, or many?
Well, this is Dave Castle from Care Equality, and I'll take a first crack at that. Oftentimes when you simplify down some of the things that we're doing, and especially when you give us a topic around trust frameworks, we're going to say some very similar things. But in reality, all of us up here, for the most part, are doing complementary things. And I said earlier that there was any element of the trust sort of constellation is often necessary but not sufficient. All of us are generally filling roles that are complementary and independently are necessary, but without the others are not sufficient. So Care Equality, for example, is generally not going to have you, your members as physicians, join us at all. You would join an existing, whether it's a health information exchange or perhaps a network that's operated by the EHR vendors or some service provider offering that's out there. You would connect with them. They would connect you to others through the Care Equality framework. And so we are nothing really without Commonwealth, without the health exchange, without the chic members. So at least from my perspective, it's definitely not that you're going to have to pay to join for 8 different exchanges. We are all playing different roles in the ecosystem.
As far as direct exchange is concerned, it would be possible for you to have one direct address, and you could use that at all those facilities if you wanted to. It really comes down to the competitiveness of those hospital systems that you're working at, and whether they want to cooperate or not with respect to providing you the availability of that exchange. A lot of this is workflow related. I mean, honestly, what is the point of health information exchange in the first place? It's really to provide information for providers to use in a timely manner when they need that information. And the technology by itself does not provide that workflow. It does not provide the collaboration between the organizations. It doesn't provide a way to ensure that those organizations are actually going to use it in the most efficient way. So there's some stuff you have to do locally to make any of this work.
And just to maybe compound that a bit is to think about it from the perspective of the consumer who sees you, who sees 9 docs, has to interoperate with 9 docs, sees doc number 2 is interoperating with 9 other docs. So the solution to this problem is not something that any one of us could solve alone. We have to solve it together. And to make it useful to the consumer should be a metric of how much success we've achieved.
And a very quick comment from a digital bridge perspective, your hospitals, your many providers, ambulatory providers and labs have to report to public health locally. The idea through digital bridge is that we will be connecting and connected to this type of trusted networks, not creating a separate yet another one that you would have to connect to. So there is that leveraging point. If we were to get into the business of giving advice up here, I'd say, you look at your community, your 9 different EHRs, and one thing that is common across all of us is that the EHRs or the HID vendors more broadly play some role in all of our ecosystems, and often a very central role. So a good place to start is with those EHRs to figure out what it is that they, what it is that they advise and where it is that they can go, and what the business case is, because we are solving slightly different issues up here, all of us. But to Dave's point earlier as well, we're also figuring out how to connect with each other, because that's going to provide tremendous value. So if you are looking for the Commonwealth solution, but you need to be able to connect to carrier quality implementers, you have the ability to do so now. If you need to connect to the local HIE, then either through carrier quality or through Commonwealth or through the HIE directly, you can connect to the others. It will still come down to you having to know what it is you're trying to solve, and having that discussion with your vendors to figure out what solutions they can best provide in the context of your providers and the context of your patients that's actually going to be used. But the good news is, you won't have to subscribe to all 8 by any means. That'll be a poor outcome.
So if we were looking at what is trending, if this were a debate and we were looking at what's trending online, we would see patient matching just going off the screen. That seems to be the #1 topic right this minute. And we're also getting a lot of questions about patient identification, how to identify patients. Do they have a right to be identity proofed in an office? Is there a PIV card potentially involved in this scenario? So a lot on matching and identification. Could I ask everyone to sort of give their quick thoughts on that?
Well, the patient matching issue is very complicated, and it really is, in some ways, is related to identity as well. Patient matching that's currently done now is done algorithmically by almost every single institution that has to deal with the patient. If there were a universal identifier, then we wouldn't have that problem. I think the issue of identity proofing is really much easier, because identity proofing can be done remotely and it can be done in person. If you think about when I go to my orthopedic surgeon, I have to give my credit card and my driver's license every time I go. That is an identity proofing step that, if it were recorded as such, could lead to an identity in cyberspace very easily by virtually every healthcare provider organization in the country. Now, they record that information, but they do not record it as an identity proofing event and I think they could make it much easier for patients to be identity proofed in person, which is of course the best way to do it. So those are related. If you had a strong, just for example, take your direct address, first name dot last name at direct.healthcareproviderorganization.com. That address bound to a digital certificate issued at a high level of identity assurance is a tremendously strong identifier. I'm not suggesting it become the national patient identifier, but it could. It's a very, very strong identifier.
Yeah, so I think I agree. ID proofing is important. It's interesting in healthcare. This is Ryan with the Karen Alliance. It's interesting in healthcare. We have the world's greatest ID proofing system in the world. We have more providers out there ID proofing more individuals than any other system on the planet, right? Problem is we just don't trust each other, right? So there's this idea that if we could develop a process, somewhat to Dave's point, that we can all agree on, that there is a standardized way in which we're ID proofing individuals and we can learn to trust each other across systems, it becomes valuable. I think what's interesting is when you get into remote ID proofing, where you actually are not in person, you're not there in person, you can actually do it online where we do it today. Now, at the Karen Alliance, we had to go outside of healthcare to figure this out, partly because Dave and I haven't spoken yet, but we need to as it relates to what's going on, but partly also because banking and telecom have figured this out. They spent 25 years on this. You know this because you have a phone, and that phone remotely ID proofs you, and there's a reason for that. There are organizations that are out there that have learned and have actually developed an institution of trust between each other to be able to start exchanging information and remotely ID proofing individuals. So, and it's different than authentication. ID proofing is very unique. It's trusting that I am who I say I am. But we are looking at those types of industries to, again, focus on open standards. There's a lot of vendors out there that are doing this, which is great. It's wonderful. But we're looking at open to be more universally adopted.
Just to sort of build on what you said there, the idea that there's one way to do this and only one way to do it correctly for a sufficient level is probably erroneous. I don't think that's what you were trying to convey. In the Smart on Fire universe, we're looking at different ways of doing this, using different applications, using PKI infrastructure such as those proposed and used by Direct Trust and otherwise. But I think the thing that we always have to bear in mind is what is the burden to the consumer to do those things? And further, what is the burden economically on the healthcare system to pay for those identity proofing events? So, as criteria, we really need to think about, will consumers use this and will it get paid for in order to solve both identity and identity proofing?
And again, from a community HIE perspective, it's a problem. It's going to continue to be a problem. And to suggest that there's a silver bullet just isn't the answer. Many folks who receive healthcare treatment, and I'll pick on my name, Richard Thompson. Am I a Thompson with a P? Am I a Thompson with an H? Am I an O-N or an E-N? Am I a Richard? Am I a Rick? Am I a Ricky? Am I a Richie? Am I a Dick? Never mind. The point is, until we adopt some standards, most of this work is about people and process. It's not about technology. And that's going to take more work, more effort, and I don't think technology in and of itself can ever be the solution. I think it's going to take local communities working together with local hospitals, ambulatory care practices, human service suppliers, behavioral health to get this right. And the beneficiary. Well, it's all about that beneficiary wanting to make sure that things are consistent.
One thing I'll add to this, when you're building Commonwealth, one of the things we realize is in a world that you're doing query and retrieve of data where the patient identity matching is actually really critical, this is an issue actually we tackle as well head on. We don't have a national identifier, so we could try to do things in lieu of that, everything from biometrics to your driver's license and so on. And we've experimented, and I think to Aaron's point, there are going to be a lot of different solutions that work out there, at least help, but no silver bullets. But we also realize that there is an opportunity to get that interaction that happens there in the clinic between the doctor or the nurse and that patient to be an opportunity for the patient to say, yep, those are my records, match them up. No, those are not my records, don't match them up. As well as the opportunity to say, well, what if you gave those controls to the patient so that when they went home and they had looked on their, favorite PHR app or a portal or something, they'd see there, here, here are the records that Commonwealth has matched up for you. Here, you can check or uncheck them. It's a set of controls that gives you the sort of empowerment, whether or not you really use them. And a lot of patients won't use them, but they'll be happy to know that they're there. And for some of them, it'll be really important that they can use them. So that's one way we've thought about it. How do you tap into existing social interaction and give people a set of controls so that we can do what we're doing, knowing that the patient feels empowerment and we're still able to get their data from out there.
And I think that that's a popular approach that, we see folks at the Michigan Health Information Network pursuing with their statewide consumer directory, so on and so forth, is self-correlation of these foreign key identifiers at different enterprises.
Let's move, got a question in the room.
Okay, so my name is Bruce Schreiber. I'm the Chief Technology Officer at MaxMD. We're a Direct Trust HISP. I'm also on the board of Direct Trust. You're actually moving in the direction of the answer to my question right now, which I'm very pleased with. There's a difference between identity proofing and authentication. And NIST has recently published 863-3, which clearly separates them. And so I'd like each of you to talk a little bit about where you see the importance of identity proofing versus where you see the importance of authentication and how we can federate that.
Well, I think that the NIST standard that you mentioned is interesting because you're right, it does actually separate it, and it actually also talks about this idea that we need a persistent token as well for user access, which is a very new concept, but it's something that is, I think, relevant to this space, and it's relevant in other spaces. I think to your point about, we've been tackling this as well and trying to understand, from an authentication perspective, that's applying the username and password, single sign-on capabilities. We're doing this again in our consumer lives with Facebook and Twitter and social media, et cetera, related to how this actually operates. But when you get into actually identity proofing individuals, that's where it gets, as we've all mentioned on it, and it becomes, again, I want to be clear about something. I don't think it's an impossible problem to solve. I really don't, because it has been solved in other industries. So I just want to make sure that's clear. It's impossible in the sense that how we've looked at the problem for so long has been in the sense of looking at it from the standpoint of exchanges that we are familiar with regarding to provider-to-provider exchange, which makes it difficult. Now, to the point that was made earlier, and I agree 100%, we have a people process issue with regards to the fact that we don't control how people actually enter data into systems. Sequoia did a fabulous report, I don't know, it's 2 or 3 years ago now, when it was looking at opportunities where they said, look, Intermountain Healthcare looked at it and said, look, there's ways in which we're entering this data that's completely inconsistent, but if we were to actually establish internal processes for how to enter the data, it became a lot better. They had a much higher rate of consistency on how they actually identified individuals within their core system. So it's a combination. I definitely agree. Technology is not the end-all be-all solution. It involves both process and technology. But for the standpoint of how do we get to that endpoint, I do think we need to separate authentication from user proofing. I think it's definitely 2 different things.
Let me try and just quickly define 3 different things that are related and always get confused. Authentication, ID proofing or verification, and authorization, okay? So ID proofing is an event that occurs that establishes your identity in cyberspace because you want to exchange information of some kind over a network, all right? The end product of identity verification or identity proofing is a credential of some kind, full stop. When you authenticate to a network or to an app, you take that credential that you have gotten as a process of identity proofing and you used it. And that's, somebody trusts that. It's a digital certificate, or it's a ID or a password, or it's another number that you get because it's been given to you offline. That is the difference between authentication and authorization. And that document for the federal agency does a really good job of explaining the differences and laying out all of the different parameters associated both with authentication and ID proofing. Authorization is something I've been ID proofed. I've authenticated to the network. Now what rights do I have to see the information that I'm requesting, for example, in a query? Because I'm a doctor, I'm licensed in three states. That doesn't mean I have authorization to see your medical records, because I may not have ever established a relationship with you as a patient, and therefore whoever holds those records has to take that additional step. That's really complicated. In comparison, authentication and ID proofing are well established, and we know how to do those.
And I'm going to point out the case of the octogenarian, but in the case of my 97-year-old mother-in-law, so who has rights to her records? She's not going online. It's not going to happen. We still need to interpret and gather and make this stuff work. So once again, it's not one size fits all. There will be surrogates. There have to be, and there's more people and process that has to happen.
We're gonna get to Dave here for a point, and I think then we're gonna have to move on to a couple more questions because we're running close on time.
Yeah,
I wish we had 3 hours for this.
And just briefly, this is Dave Castle from Care Quality for those who are on the phone. Speaking previously, by the way, was Dr. David Kibbe and Richard Thompson were from the Chic group, were the previous speakers. Just to tie back the identity proofing, the authentication and authorization to sort of the broad overview topic of the day on trust frameworks. You know, the role of a trust framework then within that whole infrastructure of having established identity proofing and establishing authentication is to really identify, okay, what are reasonably trusted ways to do identity proofing? Who can certify you as having accomplished those steps to do that? Who then can authenticate you to that identity that you've established, and using what means? All of those are questions that admittedly are kind of down in the details a little bit, but are not necessarily something that every trust framework needs to establish in the details, but needs to at least have a structure it can point to in order for any of this all to be trusted. So there really is a fundamental issue there, especially when you want to try to get consumers involved, of how you do the identity proofing, especially the authentication to it. We have a little bit more experience with how to do that once the identity is really established. But doing that is critically important, and having a way to do that that's trusted is really within the province of the trust frameworks.
Got a question over here.
Hi, I'm Lonnie Ray. I'm CEO at Metal. I'm kind of speaking with a different hat, though, which is of being a patient and an advocate on the notion of identity proofing. Most of us in this country have had our social security number stolen at this point, and most of our data is not secure. So starting out with that assumption that if we assign immutable numbers, that's likely to result in the same way that history has already shown us. That being said, if we're drawing from the banking industry does do this quite well. Notably, credit card numbers are manufactured in a way where they are randomized at different locations, passed out multi-factor authentication with a secure physical token. Those numbers, if I report fraud, and I personally have had people or someone take medical care under my social security number. So it's not a hypothetical. But for my credit card, when someone steals my credit card, which they inevitably will, I can report it stolen and get a new one. I think wearing that hat and saying, as you're considering how you construct these frameworks, please do be considerate of this experience, not to mention the fact that there are records that exist that are just not mine. And I would like to be able to say that. I do think that centering it around the patient ultimately is what needs to happen, that for as long as we continue to try to link up and identify us at multiple different discrete databases without patient intervention, there will continue to be error and issue that occurs that affects the care and the livelihood and lives of individuals. So my ask is not directly a question, although it's more of a request on to each of you to consider how you are doing this.
Well said. This is Dick Thompson again. I came out of that industry. The one key difference is it's one thing. The financial industry dealt with this by saying, we're only going to make you responsible for a $50 charge for an unauthorized credit or debit card transaction. In this particular environment, if we make a mistake clinically, we're not talking about $50 here or the loss of money. We may be talking about the loss of life. So this, your plea for getting it right, I think is well heard by all of us here. And yes, the financial industry is a good model for this, but I'm going to call it eccentricities, variabilities, and the nature of the esoteric kinds of things that we as humans require make this a problem. But I think all of us up here would agree that we want to get it right.
I think it's important to note that Lonnie's comment reflects a lot of what we're hearing online right now, and a lot of the questions coming in reflect that exact same sentiment.
And I think, from a national trust framework perspective, thinking about just looking back to what worked in other industries and trying to reapply it would be myopic. There are many new methods that are emerging that are more robust and versatile, that are better fit for especially a consumer-centric model that we should explore.
One quick from Dr. Lewis.
Yeah, thank you. I'd like to follow up on John Lund's. I'd like to follow up on Walter Suarez's comment about being a user of other networks. And one of the things we face in public health is that there's not a great understanding of what the authorities are for public health to get data. And in fact, in some circumstances, it's about state law and regulation. But we have a dependency on networks like yours. And I was wondering if you could just perhaps run through and identify which have public health explicitly articulated in their trust sharing agreement. And maybe we could talk a little bit about that going forward too. Thank you.
This is Marianne Yeager with the Sequoia Project. From the eHealth Exchange perspective, public health is certainly part of the permitted purposes and has been discussed at length, in particular around electronic case reporting, but even more broadly. And you're right, there are these nuances of on whose behalf is some of this occurring. Is it on behalf of the agency? Is it on behalf of the provider? And sort of the shifting of that. One of the challenges, and this is getting down in the weeds, and I'll bring it back up, was, well, okay, well, if it's really the agencies don't really want it to be on their behalf, rather have it be on the provider's behalf, which then establishes a business associate relationship. So you get into all this circular sort of discussions. So what the eHealth Exchange is contemplating is by amending this legal agreement, again, this is something that was not contemplated 8 years ago, and our world is going to change a year from now and 6 months from now. We have to be able to evolve these things and to get into these very, very nuanced scenarios. So one solution is to actually, when this agreement and the trust framework is amended, is to add a business associate agreement on it, so that automatically at the network level, to the extent to which there's a business associate arrangement triggered, that covers it, and that would unlock some of these very nuanced opportunities that have been untapped because of this, on whose behalf and the argument, and everybody's trying to avoid the risk. So, but eHealth Exchange sure does.
I want to go back to my focus is public health has an action where they need to inform the person who was sick and being able to reach out and share information with them. And if we, carve out consumers, in the long run, we've crippled what we could possibly do for public health.
Yeah, thanks for your question, John. Direct Trust operates a network that is a platform for interoperability, and health departments are using it all over the country. One of the limiting factors in the growth of the use of health departments at state and local levels in making use of direct exchange has been that they often don't use electronic health records. It's the same thing we're seeing with federally qualified health centers, is that as they start to use electronic health records, their ability to access direct is much amplified. Same thing is true with health departments, but there are more and more health departments that are using direct for care coordination with other private sector components, but also for a collection of data and surveillance, because it's a very inexpensive way to move data into a repository.
Almost all of the Strategic Health Information Exchange collaborative members, in one way or another, report to public health as a business associate of a covered entity, whether it's for cancer registries or disease surveillance states or whatever it might be. But the points about how much digitization has occurred, we're still working on some of that too, particularly as it relates to some of the human service agencies. They're still on fax machines and a legal pad.
So from carrier quality standpoint, public health is explicitly articulated within the implementation guide for query-based document exchange. Now, it's subject to, as you were alluding to, John, the local state regulations, and anyone actually, how they respond to those queries is a different matter. As a matter of practical operations, this is not really something that's widespread or really occurring in any significant amount today. From the carrier quality perspective, we obviously hope to see that changing.
What I've noticed in Commonwealth is two things. One is our members, particularly the EHR members or the HIT vendors who have been asking to be able to use the network now to connect to a variety of other use cases where otherwise it's expensive for them to connect one at a time. And I'm pretty sure that's a very similar story to what's going on in the HIEs, eHealth Exchange, and so on. Conversely, what I see is public health agencies making almost ludicrous investments in doing pilot projects, which would pay for subscription to everybody here in 1 year and actually get the whole country to the extent that we all have broad enough networks. So there's a little bit of education as well that also has to happen. And I know that in Commonwealth, very similar to carrier quality, we have a set of different types of data use that you can use. Right now it's academic. We're not actually doing any public health, though we have a number of public health discussions happening with various agencies. But to the extent that it's partly an education process, but people realize, like, hey, if you want to communicate with thousands of providers rather than paying $2 million for this suburb of Philadelphia, pay pieces of that and get into at least much broader swaths. There's an opportunity there, and the education level just hasn't hit in public health as yet.
I need to.
Just a quick comment from Digital Bridge perspective, and just to say, I have taken mental notes of all your responses, so I now will follow on each of you. Thank you.
I wanted to end by taking another look at what we're hearing online, and we've been able to aggregate a lot of the online questions, and a lot of them reflect the questions that have been asked in the room. But one final question from the online audience is, we as providers cannot afford multiple incompatible trust frameworks. Do you agree, and what can be done to either merge them or make them fully interoperable? That's a big chunk.
It is, and it's an excellent question, and they're absolutely correct. So it's completely reasonable and appropriate for individual health data sharing networks, whether it's an HIE or it's a Commonwealth or eHealth Exchange or a multi-HIS network, to have their own trust agreements. But if you have a home network, your home network should be able to connect to others through an overarching trust framework, and that's really the function that carrier quality has served. And whether, irrespective of its query, enabling query across here, so the idea is the compatibility isn't trying to get compatibility or having everybody agree to 8 different frameworks. Is you have your home network, your home framework, that is then bridged and enabled across a national level framework. And that's what we're doing. We all work together. We talk all the time and trying to tie together and integrate what we're doing in a way that is more recognizable to the public. And so we see our connection points. David and I were talking about it just, this morning, and there are other opportunities, but I think that is already in flight.
Yeah, I'll echo that comment. Again, it comes down to what is it your primary objectives are and your primary mission is, and then from there, one thing that we do see happening, and you can almost tell it from just interactions on stage, but we've all talked about various initiatives where we're connecting. A number of us, in fact, or just about everybody here, also has networks who are members of their own organizations, nonprofit and for-profit kind of networks that exist out there. So I do agree that I don't anticipate that providers and end user patients will be paying for multiple networks at once. But certainly, first of all, you may be paying for more than one. So I'm certainly not going to preclude that because it may have just very different functionalities. At the end of the day, the internet is different from, connecting a microwave up to it. There's some things which just don't work, quite right. Not perfectly logical. But there are other places, and that's why Commonwealth Carrier Quality, Commonwealth NATE Direct, so many of these organizations have started taking the baby steps towards bridging to each other in lieu of a national framework.
So this will be the plug for your friendly neighborhood local health information exchange. Much of healthcare is local, and as Dr. Kendrick pointed out in his presentation and his overview, most of the health information exchanges also use connectivity standards, whether they are around eHealth Exchange, whether they're around Direct, whether it's with Commonwealth and Care Quality. You kind of go from the bottom up. And in order to take care of a patient who's vacationing in Colorado, we needed to find a way so that the doctor in Oklahoma could be informed of that care event. But those are the smallest percentage. So we work pretty hard to get the lion's share done first, and then we work to get the rest.
Yeah, and I want to circle back to a point that Marianne made in her response here, which is that any network, any data sharing effort is going to have a trust framework of sorts that is associated with it, because it's going to have data sharing agreements, it's going to have a contractual underpinning for its operations. That doesn't mean that just as you don't have to join all networks that exist, you don't have to join all these trust frameworks that exist. It's kind of the same concept. And again, getting back to the point I made earlier, while we are talking in similar tones about the way we handle trust, we really are serving different functions. And again, the role of Care Quality is, as Marianne alluded to provide sort of that overarching way of connecting different networks, so that they can continue to provide all of the wonderful value that they're providing, but still for common use cases connect to one another.